On this week's 51%, we speak with UC Davis professor Mary Ziegler about the concept of fetal personhood and why she believes it is the ultimate goal of the anti-abortion movement. We also sit down with Dr. Jamie Trevino to clear up some birth control myths and discuss new guidelines around managing pain for IUD insertions.
We should be having conversations with our patients about what pain they might experience.
I'm Jessie King. It's all up next on 51%.
I was standing around like one of those girls I had seen in a movie. The whole world was a movie back then. I had my sunglasses on, I wanted to be seen without seeing shy Lolita. I wasn't really in it, I didn't really get it.
You're listening to 51%, a WAMC production dedicated to women's issues and experiences. Thanks for joining us. I'm Jessie King. A couple weeks ago, we spoke with the president of Planned Parenthood about how President Trump's One Big Beautiful Bill Act would bar the organization from getting any reimbursements from Medicaid and essentially threaten their financial operations. That bill ultimately passed and was signed into law by Trump on July 4th, although at the time of this taping, a judge has temporarily blocked that specific provision from going into effect. 3 years after the fall of Roe v. Wade, there are still seemingly countless legal battles being waged over abortion rights in the U.S. Our main guest today is UC Davis law professor Mary Ziegler, who is one of the country's leading scholars on reproductive law and history. She's written 7 books on the subject, and her latest, called Personhood, dives into what she says is the next frontier of the country's abortion debate. She says the ultimate goal of the anti-abortion movement was never just to overturn Roe v. Wade, but to establish what she calls, quote, fetal personhood.
There are a lot of ways you could imagine what a personhood claim is, and people in different disciplines actually define it differently. So if you're a bioethicist or a philosopher, you may have a different definition in mind. Different religions obviously mean specific things by personhood, but the claim I'm talking about is one about our Constitution, and it's essentially that the 14th Amendment, which recognizes due process and equal protection, is that the word person in that document applies the moment an egg is fertilized. So that would mean that an unborn child or fetus or embryo has the same rights that everybody else does. And that would be consequential across a variety of contexts.
I know you say this isn't a new idea. It dates back to the 1960s. But has it changed over the years? Is this the same idea of fetal personhood that I guess was around back then?
Not really. So I think part of the beauty of fetal personhood as a tool for social movements is that it could mean different things to different people. So there was sort of this core idea about rights beginning at fertilization. But then a lot of the other questions, like how would you enforce those rights, weren't really required to have an answer because courts just weren't going to recognize fetal personhood because of Roe v. Wade. So what people meant by the concept was both contested and changed over time. And now I think often if you hear this idea, it comes along with the idea of criminalizing some kind of conduct, right? That could be abortion, it could be IVF, it could be taking a pregnant person off of life support. And that's not an inevitable development or the only development we've seen.
Yeah, let's talk about how this would actually play out legally. You know, what would fetuses and embryos being treated as people mean in our everyday lives?
I think the answer to some degree is that we don't know, right? Because again, the anti-abortion movement hasn't fully worked all of these details out, and people within the movement disagree about really important salient questions. So there's some things we can be pretty sure about, that there'd be national restrictions that would override ballot initiatives on reproductive rights. We can be pretty sure that there would be radical transformation of how IVF is practiced in the US. And other than that, there are a lot of unanswered questions. So for example, how would you count fertilized eggs for the purposes of census drawing? Or how would you deal with that issue in the context of inheritance or child support? I don't think all of that's been worked out. And there are other questions that are being openly fought about, in particular, whether you would need to punish women who have abortions for that decision if you recognize fetal personhood. So I think there's definitely a Pandora's box feeling to the concept where we just don't know exactly what it would entail.
I think that's a good point, too, that this is about more than abortion and IVF. I didn't even think about how it could potentially impact wills or child support. It sounds like this would factor into pretty much every aspect of our lives.
Exactly. And I mean, and on the flip side, I think you're also seeing, and one of the things I think that's striking about fetal personhood is a topic of discussion, is that a lot of Americans look at it from the other side and say, why is it that we punish people? If we really think that a fertilized egg or a fetus or an unborn child is a person, why isn't the state obligated to do more to help pregnant women? Like, why don't pregnant women get to drive in the HOV lane, right? Why aren't there more protections against pregnancy discrimination, right? And so I think we're also going to see a more robust debate about, from the standpoint of Americans who don't like the criminalization, but who may think that life in the womb has value. That isn't a perspective you hear much in politics, but it's definitely one that's present in the broader American public.
Well, now that Roe v. Wade has been overturned and you see abortion restrictions popping up in roughly half the country at this point, this might seem like an idea that is more achievable for the anti-abortion movement than it was, say, even a few years ago. So I guess, how are these kinds of ideas typically advanced legally? How do you gain ground on something like this?
Well, I think it's not necessarily that it's any less of a moonshot from the standpoint of popular opinion, because we've seen since Dobbs that there's even less support for abortion bans than there was before, for the most part. And personhood, as I mentioned, at least as it's currently being interpreted, would lead to probably more stringent criminal laws than the ones we currently have. And so it's not necessarily the case that the public wants that any more than they did before Roe was overturned. It's rather that the courts might be willing to sign off on that. So the personhood movement once advocated for a constitutional amendment recognizing fetal rights. That was in the GOP platform for decades. They've given up on that and now say essentially that the Constitution's always recognized fetal rights, and we just need judges to say that. So the strategy has really relied on changing state laws and primarily on convincing state judges and federal judges to embrace this concept, regardless of what voters think.
Obviously, we have a Republican president and Republicans control Congress. Do you think it's possible we could see legislative movement on this idea at the national level, or at least a national abortion ban in this administration?
Yeah, it's a really curious dynamic, right? Because you have every branch of government under the control of people that the anti-abortion movement sees as sympathetic. And yet we've seen relatively little action so far, right? We don't have yet, we have the big beautiful bill, which is a pretty powerful national restriction, but we haven't seen much in the way of executive action from the Trump administration, at least not as much as you might have expected. A lot of what Trump has done is along the lines of what other politicians did when Roe was on the books, right? So none of the sort of major sweeping transformational changes you would have expected from the first Republican president since the fall of Roe. So I think the question is that going to change? Is Donald Trump waiting for an election? Is there a plan afoot to kind of find the right way to roll out this kind of policy? And I think the answer is just that we don't know. I think we've seen a few different patterns from the Trump administration over the years. The first being that this is not an issue about which Donald Trump himself particularly cares. Making changes on abortion is not a priority for him. He's made positive statements about in vitro fertilization. On the other hand, we've seen that he's often willing to hire people in the anti-abortion movement in his administration and to often, hand off policymaking decisions to those people because, again, he doesn't care. So I'm not sure what we're going to see. I think it's safe to assume that we haven't seen the end of national limits, but how sweeping they are, I think, is still a little hard to predict just because there's been this pattern of kind of different influences pulling the Trump administration in alternative directions.
I'd like to get your take on the case of Adriana Smith, the Black woman who was declared brain dead but forced to be kept on life support to carry a pregnancy down in Georgia. I know that situation, it's still really recent, and it's been upsetting for a lot of women to watch and read about, depending on where you stand on abortion and Georgia's laws down there. But it sounds like pretty much an exact result of this idea of fetal personhood.
Yeah, Adriana Smith's story is definitely a story about personhood. So as most people probably remember, Adriana Smith was pregnant with her second child, suffered some blood clots that caused brain death. And then the hospital in Emory in Atlanta decided that Georgia law required them to keep Adriana Smith alive because she was pregnant. There was no input given by her family. This was a decision that the hospital said had been made by the state of Georgia. So there are two ways I think you could see that as having happened. The first is that some prosecutors could have understood taking Adriana Smith off of life support as an abortion because it would terminate her pregnancy. The Georgia Attorney General disclaimed that and said that wouldn't be how the law was understood. His opinion on that is not legally binding. But the other component of it that makes it even more complicated is that Georgia doesn't just have an abortion ban, it has a personhood law. So it treats personhood as beginning at 6 weeks after the last menstrual period. And so I think Emory was concerned that even if that act, taking Adriana Smith off of life support, wouldn't be deemed an abortion, it would be deemed to violate the rights of a fetal person. There were multiple, I think, legal reasons that Emory was worried about liability in that case.
Well, aside from fetal personhood, I'm wondering if there's anything else in the landscape of the abortion debate that I guess you're keeping your eyes on right now. I mean, we've got arguments over Planned Parenthood and the Big Beautiful Bill. There's the Comstock Act in states like Louisiana and Texas, testing shield laws in New York aimed at protecting abortion providers. There's a lot to watch at once here.
Yeah, I mean, I think that there are obviously always new things happening. I think the reason it's particularly confusing or complicated is that abortion opponents are also focusing on the states. They're looking for lots of ways to advance in state courts and state legislatures. And those stories may seem small and local, but they can kind of blow up. If you look at what happened with the Comstock Act, for example, that started in the states. The same thing I think is true in federal court. We're seeing some abortion-related cases percolate up toward the Supreme Court on issues like whether states can criminalize speech about abortion, whether a new bid to end access to mifepristone, which is now before Judge Matthew Kaczmarek in Amarillo, will get going, and whether that will force the Trump administration to take a position on the Comstock Act. So I think big picture, if you're trying to kind of follow what's going on with abortion, you really need to look beyond just Congress and the Trump administration, because there's a lot of players in this story who could force action from the people with the most power, or at least make it harder for them to avoid certain issues.
Well, Mary, thank you so much for taking the time. Is there anything that we haven't touched on or anything that you hope readers most take away from Personhood?
No, I mean, I think what's important to recognize is just that the end of Roe wasn't the end of the story. And that's not just because people are continuing to fight for abortion rights. It's also because it was never the end game for conservatives either. So I think as people try to understand what's happening now and what they think about that future, that's just the most important thing to understand.
Mary Ziegler is the Martin Luther King Jr. Professor of Law at UC Davis and the author of Personhood, The New Civil War Over Reproduction. It's out now through Yale University Press. Mary, thanks for joining us today.
Yeah, my pleasure. Thanks.
Post-Roe, it's even more important to practice safe sex and know your birth control options if you're not actively trying to get pregnant. It's really important to sit down with your doctor and discuss the birth control option that is best for you, especially because every so often on social media, I see posts popping up questioning whether birth control can impact your long-term fertility, increase your risk for certain cancers, make your hair fall out, etc. People posting about their experiences online can contribute to great things. For example, after years of women reporting painful IUD insertions, the American College of Obstetricians and Gynecologists recently updated its guidelines to encourage physicians to better understand and offer pain management options for the procedure. But it can also be hard to know what is and isn't true and what is and isn't misinformation. So here to clear up some common birth control questions and myths and go over the newest guidelines is Dr. Jamie Trevino. Trevino is a practicing OBGYN in Missouri and the Darney Landy Fellow Training in Complex Family Planning at ACOG. Talking to women about their birth control options is what she does for a living, and she says there's plenty to choose from.
When we think about contraception, there is oral contraceptive pills, which is, I feel like, what people traditionally think about a lot of the time. But there's also a contraceptive injection. There's a contraceptive implant that's placed underneath the skin in the arm. There's intrauterine devices, and there's a few types of those as well. And there's also permanent contraception, like surgery on the fallopian tubes, and also male contraception as well. So barrier methods like condoms or vasectomy. And so there's a lot of different options. Some of these contain hormones, some of these do not contain hormones. And there's so many different methods that we can usually work together with our patients to find an option that works best for them.
So let's start with birth control pills, which you take daily. How do they work?
So birth control pills specifically, there are ones that contain estrogen and progestin, and that's called a combined hormonal contraception. And there's also progestin-only methods. And these combined ones I feel like are the ones that people traditionally think about when they're thinking about birth control pills. But these prevent ovulation, and that's the main way that they work to prevent pregnancy. There's a lot of different myths I see about the birth control pill and also just hormonal contraception in general. And I do want to be very clear that these myths and misinformation about hormonal contraception can be very harmful, especially in this time where access to reproductive health care and especially abortion access is so limited in our country. And so a lot of the questions I see are about possible side effects that these medications might cause, or other questions about how it might affect their mood or affect someone's libido. So a lot of questions mostly about side effects, and possibly some misinformation about what these birth control pills might cause.
So what side effects are there with birth control pills that you should be watching out for?
That's a great question. So a lot of the side effects that people can experience with birth control pills are usually short-lived, and they're usually right after someone starts a certain method. One thing that people can commonly experience is something called breakthrough bleeding, or irregular bleeding that's outside of their menstrual cycle when they start a birth control pill. Sometimes people experience breast tenderness, nausea, headaches. Sometimes people do have mood changes, but everyone's response to these hormonal birth control pills are a little bit different. And the way that one person responds might not be the way that another person responds. And so something that I tell patients is that if this certain birth control pill doesn't work for you, there's lots of different formulations, even within oral birth control pills, that we can try before switching to a different method.
I've seen some concerns online that long-term use of hormonal birth control, like pills, could impact your fertility. Is that true?
That's a question that I do get a lot as well. And there's no evidence that hormonal birth control causes infertility or changes a person's fertility. But again, if someone is experiencing these symptoms, talking with their doctor is really important about, what the next steps are.
And what about cancer risk? I've also seen concerns that long-term use of hormonal birth control could increase your risk for things like breast cancer.
For that, I would say it's really important for someone to talk to their doctor, because their kind of baseline risk of certain types of cancer may be different from person to person. So it's really important to talk to your doctor. Mm-hmm. But again, these birth control methods are very safe, very effective, and it's really important to have these conversations and to personalize your care towards you about what your specific risk factors are. There's really great evidence that birth control can help reduce the risk of things like ovarian cancer and endometrial cancer. So while there's definitely the concern and the discussion of contraception causing cancer, what I tell patients is that it's important to consider that hormonal birth control methods can actually help prevent cancer.
All right. So let's chat about the implant, which I admittedly know nothing about. What is it, and is it possible to move once it's been inserted in your arm?
Yeah, no, that's a great question. So the implant's a really great method. It is one of the most effective methods of contraception that we have. It's more than 99% effective preventing pregnancy. It's a hormonal implant that goes underneath the skin, usually in the arm, and it releases progestin. So it's a progestin-only method. It's been FDA approved to prevent pregnancy for up to 3 years, but we also have really great evidence that it can prevent against pregnancy for up to 5 years as well. So it's a very great method that is long-term, and it's also reversible, so people can have it removed at any time after it's placed as well. Sorry, to answer your earlier question too about it moving around, as long as it's correctly placed, it should stay in place. There's very rare instances of the implant migrating. So what I tell patients is if you can't feel it, then you should be talking to your healthcare provider about what the next steps are.
What about the birth control shot? I remember considering this at one point when I was younger, even though I'm afraid of needles. And my OBGYN at the time advised against it, actually, saying that it could impact my bone density over the years. Is that true?
Yeah, so the birth control injection is an injection that you can receive in the office or even inject yourself at home. It lasts for up to 3 months, and that's also another progestin-only method, so it does not contain estrogen. There is a black box warning that it can reduce bone mineral density, but the really important thing that I tell patients about that is that it is reversible. Once someone discontinues the birth control injection, the changes that we see in bone mineral density are reversed. And that also decreased bone mineral density is something that we see in pregnancy as well. And so it's really important to weigh these risks. I have a lot of patients who really, really love this method and it works really, really well for them. And so as long as it is continuing to work for them and they're able to use it consistently and continuously, then it's usually safe to continue that method.
Okay, and IUDs. Let's talk about IUDs. I know ACOG has some new guidance out on insertions, but maybe to start, we should talk about the different types of IUDs and what they do.
Yeah, so when thinking about IUDs, I like to think about them as non-hormonal and hormonal IUDs. So non-hormonal IUDs, that is the copper IUD. And that one is FDA approved for 10 years for preventing pregnancy, and we have really great evidence that it can last until 12 years. The hormonal IUDs, there's 3 different types that are available in the United States. One of them prevents pregnancy for up to 8 years, and then is also FDA approved for people with heavy menstrual bleeding for up to 5 years of use. And then the other 2 IUDs, one of them is a little bit smaller and prevents pregnancy for up to 5 years. And then the smallest one is preventing pregnancy for up to 3 years.
Obviously, this is something that you need to go to the doctor to have inserted, and ACOG has new guidelines for healthcare providers on how to navigate pain around IUD procedures. What are those recommendations? What should patients know?
Yeah, so like you mentioned, ACOG has new guidance regarding pain management around these in-office uterine and cervical procedures. IUD placement can be a painful experience for some people, and it's really important to acknowledge that concern about fear and to talk to your patients. I think the biggest takeaway from this new ACOG guidance is that we should be having conversations with our patients about what pain they might experience during the procedure, and also what options we have available for pain management and the limitations and the benefits of these options for pain management. In the past, we've had limited or conflicting guidance about the options that we have available for pain management with IUD insertions. And so this new guidance really lays out the evidence-based and patient-centered recommendations for pain management. Again, the biggest takeaway is just having these conversations with our patients. A lot of people have felt like in the past their pain concerns have been dismissed or maybe diminished by their healthcare providers. And so we should really be talking to patients about what their options are. There are different options available. And like you mentioned, some of them can cause pain by using this method, like the lidocaine injections. But by having these conversations with our patients, it should be, a partnership between us and the patients of helping them decide what is best for them. I have some patients who say, like, I will take anything that decreases the pain of this procedure. Or I have some patients that say, like, hey, I know that it takes a little bit of time for us to do the lidocaine injection, and I just don't want the speculum in that long. And so I don't want anything that will lengthen the time of this procedure. And so it's really about finding out what is important to our patients and, what they want out of this experience as well.
What are those other pain management methods?
Lidocaine sprays or creams. And I do tell patients that these sprays and creams do have to be used, and we have to give them a little bit of time to work. Again, so some patients are like, I want the shortest procedure possible. Like that's not a good option for me. And so there are limitations to these pain options, and the options that we do have aren't perfect, but we should really be partnering with our patients and helping them come up with a strategy that works for them.
And after you get the IUD, are there side effects that patients should look out for?
What I always tell patients is that it's normal to have cramping and spotting after the IUD placement, and medications like ibuprofen can definitely help out with the pain after the procedure. A lot of patients over time with these hormonal IUDs will have decreased bleeding, meaning that their periods can get lighter over time, or some people don't have any periods with the IUD, but it does take a little bit of time to kind of see what that bleeding pattern will be. So I always talk to patients about giving it a few months, seeing exactly how their body is adjusting and what they can expect afterwards.
I'm just personally curious, like when you're trying to figure out which method is best for you, do you recommend people try one method before jumping to others? Because I have to imagine, there are multiple types of IUDs. Some have hormones, some don't. You may not know how you react to hormones without going on something like the pill first. And if you're going in for a procedure to have the IUD inserted, I imagine you want to know it's what you want first. So do people typically try other methods first, or is it more a conversation with your doctor?
Exactly. Just like you mentioned, it's kind of talking it out. So when I'm talking to patients about their contraception options, I ask them what do they want in a method. And some people say, I want the most effective method. So we'll talk about what's, the most effective for preventing pregnancy. Or some patients say, I can't remember to take a pill every day, so I want an option where I don't have to remember doing that. Or some people say, I've been on the hormonal contraceptive pill for years and years, and I love this method and I want to continue it. So we talk about continuing the method. So it's really about what's important to a patient too. It's also important to mention that people use contraception for a wide range of different reasons besides preventing pregnancy. It's really important to identify what a patient needs and what they value and what their preference is when choosing a method.
Okay, so I know there's even more methods out there. We're running out of time, so I'll just give a quick shout out. The emergency morning after pill is available over the counter. It's not the same thing as the abortion pill. You usually take it within 3 days of unprotected sex. And we didn't even get, unfortunately, to permanent birth control options, but those are possible as well. Lastly, Dr. Trevino, I just want to ask, do any of these methods protect against STIs and STDs, and if so, which?
Condoms are the only method that prevents, or barrier methods, but condoms are the only method that prevent against sexually transmitted infections. And so that's another piece of talking to patients about their contraception options, is that is the only method to prevent sexually transmitted infection. And so we recommend using that as well for someone who is interested in preventing STIs.
Dr. Jamie Trevino is an OBGYN and the Darney Landy Fellow for the American College of Obstetricians and Gynecologists. You can learn more about her work and the different types of birth control at acog.org. Thanks for listening to this week's 51%. 51% is a national production of WAMC Northeast Public Radio in Albany, New York. It's produced and hosted by me, Jesse King. Our associate producer is Madeleine Reynolds, and our theme is Lolita by the Albany-based artist Girl Blue. Just a reminder that you can listen to 51% anytime at WAMCpodcast.org or wherever you get your podcasts. And you can stay in the loop on all of WAMC's shows by signing up for our weekly newsletter, Airwaves, at WAMC.org. We hope you'll join us next week. Until then, I'm Jesse King from 51%.
I was every single girl, I was nobody else, I was so sure of myself. I was 15 and a half. He was a hollow laugh. And I lost my cool somewhere along the way. The nightmare down the hallway. I had to learn how to look away. lost my cool. No electricity, hot rain on the concrete, sweet melting little